Welcome to the deep dive. Today, we're getting into a really big question in endodontics.
Yeah, a fundamental one.
Exactly. Where should root canal treatment actually stop? You know, the cleaning and the filling.
It's been debated for ages, hasn't it? The ideal apical limit.
For sure. So our mission today really is to cut through the opinions and look at the science.
Right, we're digging into longitudinal studies, actual tooth anatomy, tissue findings, all based on that great review paper you sent over.
So whether you're like a dentist prepping for a case discussion, or you're just curious about root canals, or you enjoy these kinds of scientific puzzles.
Yes, stick around. We're going to unpack some key insights here.
Okay, so let's start way back. Historically, what were the sort of main camps on where to stop inside the tooth?
Well, for a long time, there was a general consensus.
Yeah.
Especially in North American and European dental schools.
Which was?
Basically, keep everything, the instruments, the filling material, keep it all inside the root canal system. Don't go past the end.
Okay, simple enough. But then it got more specific, right? This idea of stopping short of the radiographic apex.
Exactly. That became a big focus. The radiographic apex is just the tip you see on the x-ray, yeah.
Right, the silhouette.
But the actual canal inside often ends a bit short of that. And people started talking about the apical constriction.
Ah, the narrowest point near the end.
Precisely. Cutler talked about this back in '55.
Yeah.
And others built on it, like Wayne in '82.
Okay, what did Wayne say?
He generally suggested aiming about 1 millimeter short of that x-ray tip, often tying it to the CDJ, the cemento-dental junction.
So using anatomical landmarks inside?
Yeah, and he specifically agreed with Cutler about that apical constriction being the ideal spot. He even said maybe go 1.5 millimeters short if there was, like, bone loss visible on the x-ray.
Interesting adjustment there. So this apical constriction idea really took hold early on. How did others refine it?
Well, you had Moyen in '85 also pointed to the CDJ as the limit. And Engel, he built on Cutler too. He noted that this narrow spot off the CDJ is usually about 0.5 millimeter from the outside root surface. So his recommendation was instrument only up to 0.5 millimeters short of the radiographic apex to, avoid pushing stuff out.
So very precise target zones being proposed.
Definitely. Frank and his colleagues in '88, they suggested an apical stop between 0.5 and 1 millimeter from the apex.
Still in that ballpark.
Yeah, but interestingly, they kind of downplayed accessory canals, those little side channels.
Wow. How so?
They seem to think filling them was more of a bonus, not the main objective, which is a bit different.
Yeah, you don't hear that view as often. What about Goldner and Taylor?
Goldner in '85 made a distinction. He said for necrotic or dead pulp, aim for tooth length minus 0.5 millimeter.
Okay.
But for vital pulp removal, go even shorter tooth length minus 1 millimeter.
A tailored approach based on the pulp status.
Right. And Taylor in '88 talked about a minor diameter at the apex, linking it histologically to the CDJ again.
So the CDJ and the apical constriction keep coming up.
They're central themes. But then you have Langland. His work spanned decades, from the '50s right through to the '90s.
A major figure in the field.
Absolutely. And he was a strong advocate for stopping at the apical constriction. But he had a key point.
Which was?
He emphasized that the CDJ is often irregular. It's not a perfect line. And critically, it doesn't always line up neatly with the actual apical constriction.
So you can't just use the CDJ as a guaranteed proxy for the constriction.
Exactly. Langeland argued against any fixed distance, like 1 millimeter short, because teeth vary so much, and the radiographic apex itself isn't always accurate.
So how did he suggest finding the endpoint then?
He really stressed using tactile feel what the instrument tells you, and watching for just a hint of blood indicating you've reached the periapical tissues.
Relying more on clinical feedback during the procedure.
Yes. And he warned against enlarging the canal beyond that narrow constriction point. Keep the wound small, basically.
That makes a lot of sense biologically. Now, Pecchioni, he had a slightly different angle, especially for necrotic cases.
He did. Pecchioni in '83 suggested instrumenting 0.5 to 1 millimeter short, but filling maybe just 0.5 millimeters short.
Okay, slightly shorter fill.
But here's the interesting bit. He actually thought a little bit of overfilling in necrotic cases wasn't that big a deal.
Really? That seems counterintuitive, especially compared to Langeland's view on sealers being irritants.
Totally. Pecchioni figured the body could tolerate or resorb a bit of sealer, and maybe it helped seal things better. A real contrast in philosophy there.
Wow, yeah. And finally, in this historical overview, we have Schilder. His approach was quite different again, wasn't it?
Very different initially. Schilder, through the 60s, 70s, 80s, he aimed to clean and fill right to the apex and even into lateral canals and ramifications.
So going for a complete dense fill of the whole system.
That was the goal.
Yeah.
His techniques often involved instrumenting slightly beyond the main canal limit. He believed strongly in sodium hypochlorite, the bleach solution, to dissolve debris.
And he wasn't worried about the constriction.
He felt the CDJ and constriction were too variable to be reliable limits. Though it's fair to say later on, he did modify his stance slightly, suggesting stopping at the canal terminus.
Interesting evolution. So, okay, we have these two main camps emerging. Finish short, generally at the constriction, versus go right to the end, or maybe even a bit beyond.
That sets the stage perfectly. How do we try and settle this? We look at the clinical outcomes.
Right. Let's get into the statistical studies, the long-term follow-ups. What do they tell us about success rates based on where the filling ends?
This is really where you see patterns emerge over time. Strindberg's study from 1956 is like a classic.
What did Strindberg find?
Following patients for years, he found the highest success rates when the root canal filling stopped about 1 millimeter short of that radiographic apex.
1 millimeter short, showing the best results early on.
Yeah, and that study became a kind of benchmark for later research.
Did later studies back that up or find something different?
Largely, they back it up. Swartz and colleagues in '83 looked at like over 1,000 teeth.
Okay, big sample size.
And they found that canals filled past the apex overfilled were 4 times more likely to fail than those filled short.
4 times. That's significant.
It is. And Marin in '89 found similar results. Fillings ending 0.5 or 1 millimeter short had a significantly better prognosis. Success dropped when fillings reached or went past the apex.
So a pretty clear trend seems to be developing in these studies.
Yeah, and it continued. Sturgeon et al. In 1990 looked specifically at necrotic teeth. Best results, 94% success when the filling was within 2 millimeters of the apex.
Within 2 millimeters short?
Correct. Success dropped to 76% with overfilling. And in retreatments, if they were overfilled, success plummeted to 50%.
Wow, overfilling really seems detrimental, especially in complex cases.
It appears so. Smith et al. 93, again, higher success within 2 millimeters short, lower success with long fills. Friedman et al. 95 found extruded sealer stuff pushed at the end was linked to much lower success, like 56% versus over 80% without extrusion.
The numbers are pretty compelling. It seems staying short is consistently linked to better outcomes. What about differences between, say, specialists and general dentists?
That's a really important practical point. Studies consistently show specialists or treatments done under special supervision have much higher success rates. We're talking 90, 94%.
Compared to general practice.
Where reported failure rates can be much higher, sometimes unfortunately around 50%. And some studies specifically linked inadequate fills both too short and overfilled to more problems, like periapical lesions in general practice settings.
Which really highlights how technique sensitive this is.
Absolutely. But pulling all this longitudinal data together, the strongest message is that a well-done filling ending slightly short of the radiographic apex seems to offer the best chance for long-term success.
And crucially, there isn't equivalent long-term data supporting routinely going beyond the constriction.
Not with sufficient case numbers and follow-up periods, no. The weight of evidence leans towards staying within the canal.
Okay, compelling clinical evidence. Let's shift gears slightly now and look at the actual structure, the anatomy. What does the physical end of the root tell us?
This is fundamental. We talked about prize work, Hess, Cutler mapping this out early on. The crucial anatomical point is the main exit, the apical foramen. It rarely ends exactly at that radiographic apex.
So the X-ray spot isn't the true exit, usually.
Almost never. Gutierrez and Aguayo did a great study in '95 on extracted teeth. They found the foramen exited anywhere from 0.2 millimeters to almost 4 millimeters short of the radiographic apex.
4 millimeters, that's a huge variation.
Massive. And often they found multiple tiny foramen and not just one single exit hole, maybe up to 6 per root.
Wow. So how does that complex anatomy mess with our X-rays?
Big time. You can usually only see the foramen on an X-ray if it happens to exit towards the side mesially or distally.
Okay.
If it exits towards the cheek or the tongue, buccally or lingually, it's basically invisible on a standard X-ray.
Yeah.
Meaning you could easily push your instrument right out the side without seeing it on the film, unless you're incredibly careful with your measurements and tactile sense. Unnoticed over-instrumentation is a real risk.
So a filling could look perfectly short on the X-ray.
But actually be poking out the side? Yes. Rakuchi documented failures like this looked short radiographically, but the filling was past a buccal foramen.
That's a bit scary clinically.
It highlights the limitations. Plus, remember the main canal often splits into smaller branches way down in the apical third, and you have lateral canals branching off anywhere.
And those are impossible to clean properly with files.
Pretty much impossible to instrument effectively. They're too fine, too complex.
So this picture of the anatomy, multiple exits, variable locations, branching canals, it sounds like trying to reach the absolute radiographic tip is risky.
That's the argument. It strongly supports stopping at the apical constriction. That narrowest point, usually 1–2 millimeters short on average.
But with lots of variation, as Langland warned.
Exactly. That average is just a guide. Stopping at the constriction aims to keep everything within the main canal, avoiding disturbance to any remaining vital pulp tissue or those complex ramifications near the true end.
Respecting the natural anatomy seems key.
It's the safest approach anatomically.
Okay, clinical success points short, anatomy points short. What about the biology? The histopathology and microbiology. What happens at the tissue level?
Right, let's look at the body's reaction. Davis, way back in 1922, drawing from Hess's anatomical work, was probably the first to really stress that managing the apical tissues well was critical for success.
And later studies confirm this with actual tissue analysis.
Oh, definitely. Particularly looking at vital pulp cases. Several studies, starting with Hatton, Blaney, then Nygaard Osby, Laws, Nyborg and Tullen, Engstrom and Spangberg. They generally found better healing if some healthy pulp was left at the apex.
So a partial pulpectomy, basically.
Yes, rather than ripping everything out. And Seltzer's work in the late 60s was really clear. Milder tissue reactions when instruments stayed short, and negative reactions, inflammation, when filling materials were forced out beyond the apex.
That makes biological sense. Don't injure healthy tissue unnecessarily. But what about necrotic cases? We usually think the pulp is totally dead then.
That's a really key point, and often misunderstood. Just because a tooth tests dead doesn't mean all the pulp tissue inside is necrotic.
Really? How does that work?
Langland, again, did meticulous work on this. Pulp death, usually from decay, is often a slow, patchy process. Bacteria invade certain areas, but surprisingly often, vital, relatively healthy pulp tissue can survive down in the apical part.
Even if there's a lesion, an abscess visible on the X-ray?
Yes. Even with a periapical lesion, the inflammation might be worse coronally, near the decay, but it often lessens towards the apex. That apical pulp can hang on, kept alive by the blood supply.
So the lesion might be caused by toxins leaking down, not necessarily bacteria in the apical pulp itself initially.
Exactly. It can be caused by disintegration products, toxins, inflammatory mediators trickling down from the dead pulp higher up. The apical pulp might still be vital, just reacting.
And the blood supply down there is pretty robust. It doesn't just get strangled.
No, the strangulation theory is largely dismissed. Yeah. There's a rich network of vessels entering the apex. It keeps that tissue potentially viable for quite a while.
So the clinical takeaway from that biology is...
It reinforces stopping at the apical constriction. Even with a lesion, you want to avoid damaging potentially vital, helpful tissue right at the foraminal opening. Preserve that natural barrier if possible.
Even knowing that eventually the whole thing might become necrotic and bacteria might move into the lesion itself.
Yes, because the primary goal is to clean and seal the canal system to that point. If you do that effectively, eliminating the source of irritation from within the canal, the periapical lesion has the best chance to heal, regardless of whether bacteria eventually got into the lesion itself. Healing comes from cleaning the canal.
Got it. And what about those lateral canals? Schiller wanted to fill them. What's the biological reality there?
Langland showed the tissue inside a lateral canal usually mirrors the main canal where it branches off. Healthy main canal pulp, probably healthy lateral canal pulp, necrotic main canal. Necrosis progresses into the lateral canal.
And can we clean them?
Not really with instruments. They're just too small and inaccessible. When you see sealer puffed into them on an X-ray, it was basically forced there under pressure.
So it's not really cleaning, just pushing material in.
Pretty much.
Okay.
And those lateral canals also get some blood supply for the periodontal ligament, the tissue around the root, which helps maintain some vitality. Lesions linked to them form the same way as apical lesions, irritation leaking out.
So the focus biologically should remain on the main canal up to the constriction.
That seems to be the most logical conclusion based on the histology and microbiology. Thoroughly clean and seal the main highway.
Okay, this has been incredibly detailed. We've covered history, outcomes, anatomy, biology. Let's try and wrap this up. What's the big takeaway for everyone listening?
I think the overwhelming message from all these different angles, the long-term studies, the anatomical reality, the tissue responses, is that the evidence really stacks up in favor of being conservative at the apex.
Meaning?
Meaning terminating your instrumentation and you're filling short of that radiographic apex, ideally right at the apical constriction. It just seems to provide the best biological environment for healing and the highest likelihood of long-term success.
So respecting that natural endpoint, that constriction, is key. It's not just about the X-ray image, but the actual biology.
Precisely. It's about working with the body's anatomy and healing potential, not against it, basing our approach on solid evidence.
It really makes you appreciate the complexity behind what might seem like a straightforward procedure, and it leads to a final thought, perhaps. Well, if something as focused as the endpoint of a root canal is this complex and debated, based on respecting tiny amounts of vital tissue, what other medical or surgical procedures might have similar hidden nuances? These starting points that require such careful consideration based on ongoing science.
That's a great point. It's a reminder that medicine is always evolving, always refining, always learning more about the intricate details.
Definitely something to think about. Thanks for joining us for this deep dive.